I'm Brissete. I will be presenting the case today. The title of the case is Relentless Fever. So let's start. So here's the HPI. Patient comes in because of fever and abdominal pain. He's a 52-year-old male, has medical history of HIV. He's compliant with his heart. He was in his usual state 2 weeks back, when over the course of the day, he started feeling off. He began experiencing subjective fevers, chills, and intermittent right upper quadrant and left lower quadrant abdominal pain that went to his back. The pain was accompanied by a little bit of nausea, non-bilious, non-bloody vomiting, and it has been getting worse up to a point that he's not able to tolerate PO. He decided to call EMS after developing severe abdominal pain. I will tell you a little bit more about his clinical course. During the first 7 days that he was here in the hospital, you can see that the temperature that he had experienced here in-house was pretty significant. And besides that, there was marked asthenia, nausea, and abdominal pain. Okay. I will hand it to Sani to continue the.
Yeah, and this is meant for you guys to ask your own questions. So if we can, Brissete, go back to our HPI. Mm-hmm. All right. So now we know what the chief complaint is, which is fever and abdominal pain. And there's a lot going on in this patient's history. So I'm wondering, when you're trying to determine where this abdominal pain is coming from, what would you like to know? So let's start, perhaps, if you'd like to work through review systems, or I think, Brissete, just to follow the order of your presentation, I apologize, we can start with the past medical history. So what would you consider relevant here? And again, you can use the chat or you can unmute yourselves. We'll take 1 minute.
We have a recent CD4 count.
Okay, so you would like to know how the HIV control is, all right?
Sunny, do you want me to tell that or to just wait afterwards?
We'll present it in the next few slides, so that will be okay. Just, I want you guys to throw in ideas and questions that you might want to know, or things that you might want to know, questions you might want to ask Brissete or the patient.
Any sick contacts?
Okay, perfect. What else? What else in the past medical history?
COVID.
Prior surgeries?
Good, prior surgeries. All right. And why are you thinking that, Tom?
Like obstructions.
Oh, sorry. I thought it was Tom. Tyler. Okay, great. Okay, wonderful. What else? Someone that's presenting with fever and abdominal pain.
Last bowel movement.
Okay, last bowel movement. All right. What else?
Alcohol consumption.
Alcohol consumption, really important in the history as well. Alcoholic pancreatitis, maybe. So you're starting to create a differential in your mind. How about medications, maybe? What is the patient taking, for example? All right, so I think that would be our third slide, Brissete. If you want to go ahead and share some of the past medical history with us.
Mm-hmm. So this is a past medical history. He has HIV. He reports a little bit further, to get into what we had in the chart. He saw endocrinology back in 2020 because of heat intolerance and diaphoresis. At that time, they checked the TSH and everything was normal. They asked the patient directly, and he said that he had this episode, kind of like similar episodes in the past, back in 2015 and 2018. We don't know exactly, he just mentioned that he was treated with some antibiotics and it kind of resolved, and that's all we know. Medications, you can see those, dolutegravir, emtricitabine, and tenofovir. And over the counter, he was taking some ashwagandha, elderberry, and CMOS. Allergies, nothing. Surgeries, none. Family history, he just reports hypertension, diabetes, and no autoimmune or hematologic conditions. And the social history, I think that must have been something you touch a little bit. regarding the alcohol, denies smoking, alcohol, or any recreational drug. He lives alone, has 3 children, is sexually active, 2 partners over the last 6 months, pretty much uses condoms most of the time. He doesn't report any sick contacts. About recent travels is basically Connecticut, Florida, and Minnesota in the past 6 months. We don't know anything like before that. No bug bites, and denies having any type of contacts with animals or having pets himself. In terms of review of systems, he said it was positive for chills, fatigue, fever, decreased appetite, and weight loss. Nothing in head, ear, nose, and throat. Respiratory-wise, there was no complaints. Cardiovascular, positive for palpitations. In the GI system, abdominal pain, constipation, last bowel movement was 3 days back. Nausea, vomiting, and again, passing gas. The GU system, he reported a little bit of dark urine that started 2 days prior to admission. With regards to the MSK system, he did refer a little bit of back pain, the abdominal pain going to the back. In skin, there was no rash, and neurological wise, no headaches or focal deficits. Do you want me to go ahead in the physical exam, Sandy?
How will you guys focus your physical exam? There's a lot going on, right? What would be one of the first things that you would want to check in this person's physical exam? There's no wrong answer. I just want to know what you guys are thinking so far. So someone's coming in with abdominal pain, fever, history is mostly significant for HIV. Sounds like the fever and sweating happened sometime in the past, nothing really significant or relevant. So I see Kruti is saying GI and signs of dehydration. All right, so GI exam, abdominal exam, okay. How come signs of dehydration, Kruti?
Since he has like fever and fatigue, we just want to see maybe like skin turgor or mucosa if we're suspecting any like infection, like some ruling out.
Okay, and one of the best ways to see if a patient's dehydrated is actually seeing if they have any sweat in the armpits. I know it's not something that we usually do, but it is one of the highest likelihood ratios. If we do find that the patient's dry, they're probably dehydrated. Skin turgor, the mouth being dry, those things tend to confuse us sometimes and don't necessarily speak of their volume status, right? What other things would you want to check here? Anything in other parts of the body?
Musculoskeletal, maybe back, because there is back pain as well.
Okay, all right.
Yeah. Other than that, I would check abdominal tenderness and guarding and rigidity and rebound tenderness.
What would that tell you, Venus? If there's
If
rebound
there is
tenderness.
obstruction, could be guarding. If there is an obstruction we are anticipating, there could be guarding. There could be rebound tenderness.
Okay. So you're thinking, well, maybe there's a peritonitis, there's either intraluminal, which would be sort of consistent with the nausea, the vomiting, everything else that's happening, where there could be something else going on. Okay, great. What did you find in your physical exam, Brissete?
Okay, so vital signs. Blood pressure was 116/67, heart rate of 130, temperature 38.9, respiratory rate was normal, saturating fine. You look at the weight, BMI was 25, but it's very remarkable. Like we went a little bit, the last time he was here, but was in 2020, seeing endocrinology, and you see that the weight of this patient back then was 123 kilograms. With regards to the constitutional, you see a very ill-appearing African American male. There is no icterus sclera, no proptosis, no cervical or submandibular lymphadenopathy, no thyromegaly. Cardiovascular-wise, just tachycardic, no murmurs. Pulmonary, he's speaking in full sentences. Clear auscultation, abdominal-wise. Remember the right upper quadrant tenderness and left lower quadrant tenderness. Soft, no rebound, no guarding, no inguinal lymphadenopathy. In terms of extremities, he's warm, well perfused, no lower extremity edema, and no kind of like distal tremors. Neurological wise, he's no times 3, moving all extremities, and his skin is warm, dry, and no rash.
Okay.
Okay.
So it does look like we have a tachycardic patient, and the documented fever kind of supports the subjective fever that he was reporting, right? Normal oxygen saturation, and several of the things that you guys mentioned are already here. In addition, of course, she's mentioning, well, there's no skin rash, there's no jaundice, although its absence doesn't really necessarily rule out biliary pathology, but it kind of points away. So that is also part of the abdominal exam that you're doing, right? You're connecting all the systems. The bowel sounds seem to be, I hear, normal. So those are several of the things. Do they have any devices? Are there any catheters in this patient? It doesn't seem to be the case either. So just based on this, I guess in addition to our abdominal exam, there are 3 different other body parts or systems that don't necessarily involve touching the abdomen that we should be aware of when you have someone walking in with abdominal pain. And again, I know this is not necessarily the case because we're going to be focusing on the fever, but you have to think of the thorax, you have to think of the pelvis and of the pulses, right? So any pathology in the lower chest, so lower pneumonia or infusion, could radiate the pain to the abdomen and kind of camouflage in that way. Or perhaps if you have a, let's say in the pelvis, in women, you have to think of the possibility of pelvic inflammatory disease, which is in that rare, causing abdominal pain. In other patients, perhaps it's inguinal hernia, someone mentioned before, obstruction, incarceration. So those are also sources of abdominal pain that could present. In these patients, if you check pulses and you clearly have the red flag of an asymmetric pulse, and other vital signs that we're not necessarily seeing in this case, you have to think, well, could this be like any aortic pathology? Could there be a dissection? Could there be something else going on with this patient? Of course, we'll see more later on because this is a patient that we're meeting on an inpatient ward and not necessarily in the ED. So we'll have a little bit more to discuss. Now, before we move on to Brissette's problem representation, and before someone wants to take a stab, I just want to remind you. So when we do a problem representation, it's your one-liner, right? It's that one sentence that will summarize and will highlight what's wrong with this patient, and it will help you create a differential diagnosis, okay? So before I ask one of you to volunteer to do the problem representation, just remember, you have to talk about who your patient is, so demographics, important risk factors. You want to talk about what the temporal pattern of their disease is. So, what's the acuity, right? And then is this something that comes and goes? Is it stable? And then, of course, we want to know what the clinical syndrome is. So this is where you sort of summarize the key signs and symptoms that we've already presented, okay? So with those 3 things in mind, who our patient is, what the temporal pattern is, and what the clinical syndrome is, who would like to take a stab at this problem representation, knowing that's a very complex patient? Does anyone want to volunteer?
I can give it a shot. It's a middle-aged male with a history of HIV, compliant with heart, presenting with nausea, diffuse abdominal pain, found to be tachycardic, and febrile.
Okay, great. Thank you so much, Juan. All right, Brissette, if you want to share yours.
Okay. So again, this is a middle-aged African-American male, HIV compliant with heart. No recent travel outside the U.S. Presented with subacute onset of progressive constitutional symptoms. Remember the fever and weight loss, generalized malaise, accompanied by abdominal pain, nausea, vomiting. On exam, found to be tachycardic and febrile with abdominal pain, some kind of like localizing symptom, and midden Stur's criteria. And the thing here is the reason I mentioned Stur's criteria and the reason I put the fever curve at the beginning is just to emphasize how like the diagnosis, you can like no patient goes but 3 weeks of fever, right? And that's very remarkable on him, and his generalized fatigue, his unintentional weight loss, and the abdominal pain. So I think like we should center what is most important on this patient. If you were to pick one or two things, will be again the fever and the unintentional weight loss, the constitutional symptoms, and the abdominal pain. So I'll go ahead.
Can I just stop you real quick? Because I think there's one other thing that I would say has to be in here, because I think the patient knows it, is what his CD4 count is. Because it makes a huge difference if his CD4 count is normal or above 500, right? Because he's on heart, he sounds like he's doing okay, he's knowledgeable about his disease, versus he's a typical person that comes in who's not controlled. We have no idea what his CD4 count is, right? Because otherwise we're going to be all over the place, because there really is a difference between the person whose CD4 count is extremely low versus someone who's been taking his heart for all these years. He's never had a low CD4 count, and you're going to think about a lot of other things. And it seems like this guy knows that.
It's one of the challenges of this case in particular, because it's a patient that we've known for a little bit now. They've been in the hospital for a while before we're presenting this case, but he's an immunocompetent patient. Even though he has HIV, he has well-controlled HIV.
That's what I totally agree with you, Dr. Hey, that's what I like put in complying with heart, like since the beginning.
Compliant with heart doesn't tell you what his CD4 count is.
Okay.
But there's lots of people that are compliant with heart who got started on heart when their CD4 count was 50, and their CD4 count never goes above 200, even though they're undetectable for years. And there's other people that are compliant with heart who never had a low CD4 count, and their CD4 count is 800. So just saying that they're compliant with heart doesn't really tell you what you need to know.
Okay. So I can give that now. CD4 count is greater than 200. Viral load is 170. With regards to the labs, the initial labs that the ED sent was CBC. And the CBC, you can see it was a normocytic anemia. White blood cell counts of 9.3 and platelets of 147. The COMT, the sodium 133, potassium 4.7, creatinine 1.18. There was some transaminitis, ALT 143, AST 74, bilirubin was 1.4. Alkaline phosphatase was normal. Albumin was 3. The TSH was 1.53. And the BVG was 7.46 and lactate 1.6. We sent blood cultures and urine cultures, and we have the UA. For that dark urine, there was no hematuria. Red blood cell count was 2, but there was a little bit of urobilinogen and negative leukocyte esterase or nitrates. Okay. I'm gonna head a little bit more because the whole point of the lecture is like around the fever. We did an abdominal ultrasound. The abdominal ultrasound showed hepatomegaly, some hepatic acidosis. There was no evidence of acute cholecystitis or biliary duct dilation, and the portal vein was patent. The reason I mentioned the portal vein was patent because one of the differentials of fever could be a clot, right? And that clot could be seated anywhere. And this patient came with right upper quadrant tendon. So that's something just worth knowing. In terms of the CTA, abdomen pelvis, for those that were thinking about obstruction, no bowel obstruction, no ascites. There was hepatosplenomegaly, and the only remarkable thing in terms of like lymphadenopathy was a pure splenic lymphadenopathy up to 1.1 centimeter. So remember these labs. We have a patient with fever, abdominal pain. There is no leukocytosis. He doesn't have any lactate. Nothing respiratory, no respiratory symptoms. It doesn't seem to be kind of like infectious. You did a CT abdomen pelvis thinking to find any kind of abscess or some pathology there. And now my question is, would you start antibiotics on this patient? He is febrile, tachycardic, complaining of a very bad abdominal pain. Would you start antibiotics on him? A yes or no?
I guess
There's no right or wrong answer. You can say yes because of this, or no because of that. Again, there's no right or wrong answer.
So going along with Dr. Solonia, so we have a suspected source and 2 serious criteria. So he's septic, so I would start him on the septic pathway.
Okay, sure. And you mind telling me one, like which antibiotics would you kind of choose? What are you gonna cover? That's all I wanna know. No, which antibiotics, but what do you wanna cover?
I'd focus mainly on gram negatives and anaerobes. So I go broad,
Great.
maybe cefepime flagyl.
Great, okay. So I will tell you a little bit later what we did put on this patient.
Okay.
So,
before we walk into this preset, let's talk about fever for 1 brief second. And of course, you will give us a fantastic discussion about fever later on. But if I just may, with your permission, share my screen, I'm gonna see if my terrible handwriting makes sense. So one of the things when we're seeing these patients, when we're doing a physical exam, reading labs, we always want to know objectively, what are we looking at? And I think, yes, Dr. Solonia, he mentioned this before, right? What's the evidence behind what we're doing, right? So I like to think of things in terms of likelihood ratios. And likelihood ratios are mostly just numbers that will tell us, how much a physical sign may or may not argue for or against a disease, for example, when we're thinking of, clinically or, evidence-based physical exam. Now, when we talk about likelihood ratios, I'm just going to write this here because I notice my handwriting isn't the best. We know that a likelihood ratio may go from 0 to infinite. Every time we have a value that is greater than 1, again, this is likelihood ratios, that means that there's an increased possibility that we may find the disease. We have a likelihood ratio that's less than 1, that means that decreases the probability of finding a disease. The closer a number will be to 0, then the more the probability of a disease will decrease. That's basically the point of this, right? So fever, we can define it as values greater than this, right? And it's pretty clear that, until we find a diagnosis, a definitive diagnosis of fever, or when we figure out what's going on with our patients, we really don't know. And that goes to that question, or should we start antibiotics or no? And that's technically a fever of unknown origin, right? Until we pin down what's going on with our patients. And back in the early days, and we can talk about this forever because some of us have learned about this in school, we had different types of fever, and some would say, well, whether it's sustained or intermittent, and different patterns of fever would tell us what a disease was like. We don't use that, and it's not that common nowadays. For those of you who train in tropical countries, you may know that we can make a diagnosis with a lot of certainty for certain things. Or typhoid fever tends to present in a very intermittent, like step ladder pathway, or pattern. And actually, this is related to likelihood ratios as well. So when we have a patient in whom we start antibiotics, and we'll see that this patient was started on antibiotics and persisted to have fever, and this is one of the first graphs that we saw in our presentation, that's an important sign. And that can indicate, either, our diagnosis was incorrect and this patient isn't truly infected. And I totally agree, Juan and Nadim and Juan. I think, if you have SIRS and you have a possible suspected infection, which in this case, I didn't ask you guys where you think the source of infection would be, but that's an important key to a patient being septic. Or let's say, your patient still has a fever, And I do think it is an infection. So is there anything else going on? Is it that the patient developed a complication? Is it a super impulsed infection? Is it a resistant organism, or maybe it's an abscess? And maybe that explains why the patient is still febrile despite proper care with antibiotics. Now, there are two different findings, and this is going back to when we met our patient. Our patient was saying, well, we have subjective fevers. So there are two different findings that will support this. One of them is that reported fever. So the likelihood ratio of a patient having subjective fevers, I don't know how I'm going to say this, so subjective, is actually 5.3, which is pretty high, right? We said the closer to 0, the lower the likelihood of disease. And then the second of it is, the second part of that, or the second sign, would be your own perception. Is the skin warm? So this is one of the other things that in our physical exam we can find. And I think in this case, we didn't necessarily mention more than the rashes and other things, which is still fine, right? When we're suspecting sepsis and or a patient being bacteremic and that being the source of fever, we also have some clinical signs that can tell us whether this is the case or not. Most importantly, it'll be the underlying risk factors for the patient. So actually, renal failure increases the likelihood ratio of a patient being bacteremic up to 4.6. And then other things, patients that are hospitalized for trauma, and of course, patients who have a poor functional status. If you have a patient that's bedbound, it requires a lot of attention and a lot of help from our nursing staff. If they do have a fever, that actually increases the likelihood ratio of this being bacteremia to 3.6. Okay, it's okay if my iPad just disconnected, but that's absolutely fine because we can keep the conversation going this way. Now, we mentioned chills, right? And this is something that we love to report in our HBIs. Chills actually don't increase, if only modestly, the likelihood ratio of this being an actual fever. Sorry about that. But if the patient says that they had rigors, they're shaking with, like I'm under the covers and I'm still very, very cold, that actually will give you a higher risk for, or a likelihood of this being an infection or a bacteremia. Now, patients look sick, and we always report this, and when we're giving a hand of, oh, they appear toxic, actually, this is not really that relevant when it comes to evidence. The likelihood ratio of someone being truly febrile and septic, just by them looking toxic, is very low. Now, with that being said, and keeping in mind while we're discussing, Brissete, please go ahead and share your own screen, because I can't use this anymore. Sorry.
So share and screen. Double click.
Okay.
Are you unmuted?
Okay, so I just want to spend like maybe five minutes or less. If you can throw some differentials in terms of, like, we have a patient that have 3 weeks of fever and have some abdominal pain. Basically, what are you thinking in terms of 3 weeks of fever, which we're gonna call febrile unknown origin now? What do you think could be going on with this patient? You can throw anything, honestly.
I'm gonna throw something, infection.
Okay, great.
I see here ARPAN is saying malignancy, yes.
Okay.
Weight loss, we saw lymphadenopathy on CT. I agree with what you're saying.
What else?
Okay.
We have infection.
TB and lymphoma, Bruno. Bruno, what would make him at risk for TB?
Just the HIV infection, even though his CD4 count is good, maybe he would make him actually have some risk. I'm not quite sure if
That's
there's
okay. It's not to
any...
put you on the spot. It's just to hear, what your train of thought is looking.
No, but you're absolutely right. So if someone's CD4 count is between 200 and 500, they are at increased risk from TB, right? If the CD4 count is 800, then he's not at risk from TB. So again, it really depends what your CD4 count is.
And I see Nadine is saying autoimmune, rheumatologic causes, less likely in this case, but there's always this is something that we have to think of. Now, Nadine, why do you think it's less likely in this case? Is there anything here that makes you turn away from that diagnosis?
No, but like the patient doesn't really have like a past medical history of any rheumatologic diseases like rheumatoid arthritis or IBD or anything like that. So something to think about, but I think the history of like potentially immunocompromised points more towards an infection.
Okay. And I'm reading here CMV colitis and viral EBV and inflammatory bowel disease, all very relevant diagnosis. Again, you go back to your history and some of the things that we suggest have to go sort of in hand with what we're saying, right? So unless we find any physical findings or anything in our review systems, which was surprisingly not that revealing, maybe we could say that it's less likely that it's any of these things, but absolutely, yeah, the patient's at risk, right? Brissete, histoplasmosis, is Bruno saying, yeah, and I think some of these suggestions actually will fall under what we're going to be discussing next. So in the interest of time, I'm just going to let you go ahead, Brissete. Okay.
Yeah. So yeah, that was great. I would like to share this one. Okay. This one?
Yeah.
Or
So,
can I just-
so on the, no.
No?
Yeah, select it.
Okay.
Switch screen share.
Okay, so
So that's what I'm sharing.
Yeah. so I've made like a small table. This is like basically differentials from fever of unknown origin as a whole. And I think you mentioned like the biggest buckets, right? Your infection, your malignancies, your inflammatory, and your drug fever. And I just want to like emphasize an infection, how important it is for us to do a very good physical exam. If you're thinking about fever of unknown origin and you're like thinking about that there's some infection going on, you need to ask, I think Dr. Andrade mentioned this since like the very beginning, like who is my patient? Is my patient immunocompetent or is immunosuppressed? And if it's immunocompetent, yeah, there are a lot of things that can be going on. How would you narrow that? Basically, where does my patient come from? Is he from an endemic area in the US or if he is a returning traveler? Those are things that will change my differentials. Again, if it's there's some immunosuppression going on, you want to know, okay, is it HIV/AIDS? What's the CD4 count? And is it neutropenic or transplantation? In terms of exposure, I think that's something that we can learn for kind of like future cases. If we have like fever of unknown origin, we want to know, are there in pets, are there in ticks, the seasons of the year. Our patient was coming in the spring, and he did travel along that northeast portion of the U.S. Was there any mosquito bite, any rodents, any farm animals, birds, and bats? You can see all the kind of like differentials. And those are the kind of questions that it's not something you will ask right off the bat, but if you have 3 weeks of fever and at week number 2 or 3, you have this patient, these are kind of the things that you want to start thinking about. Sexual activity, very important. In terms of malignancy, things that you don't want to miss is lymphoma, and that's basically one of the most common causes of fever of unknown origin. You can have your leukemias, and in this patient, hepatosplenomegaly, hairy cell leukemia, it's again high in the differential. Any myeloproliferative disorder or myelofibrosis, because this patient has hepatosplenomegaly, and those are the things that can give you fever and abdominal pain, right? And you don't want to forget the most common association with solid tumors will be renal cell carcinoma. This is very unlikely. And our patient, in terms of autoimmune, you want to rule out RA, rheumatoid arthritis, and SLE. You don't want to forget your vasculitis. This patient could have had like either with abdominal pain, a polyarteritis nodosa as a cause. It's very likely. You just need to like have your differential very broad. And this is not for this patient, but for you guys to have in mind, any patient that comes like with fever of unknown origin, and especially greater than 55, 65, you get an ESR, it's sky high. you want to rule out the GCA. Don't forget your sarcoid, which can also give you some hepatosplenomegaly. And in terms of your, there is a mnemonic, I made, I for infection, M for malignancy, A for autoimmune, and your drugs is your D. You don't want to forget your drugs, right? And there's a special kind of case, there's Bress syndrome. Usually you see here the latency is about 2 to 8 weeks, that's the law. And it presents with lymphadenopathy and organ involvement. And the organ that is most likely involved is the liver. We didn't see in this patient, we just saw like he was coming with fever, he was coming with some organ involvement, mild lymphadenopathy, no rational eosinophilia. So this is like kind of like less likely. And your other things, someone mentioned Crohn's disease, hyperthyroidism, your endocrinopathies, pheochromocytoma vera, thrombosis, your clots, your hematomas, and hemophagocytic syndrome. The ones I have highlighted in blue are the ones that present usually with hepatosplenomegaly, which is something, which is kind of like if you go through your history, you have a patient with fever, abdominal pain, and this finding that is given by the, not so much by the physical exam because he was very tender, but by the CT of the abdomen. So I'm gonna go back to the slides. And these are the labs that we send. You can see here, CRP is high, 137. ESR of 80, uric acid and phosphorus is normal. Your ANA, CCP, rheumatoid factors slightly elevated. Blood cultures were negative. We did 2 rounds of like blood cultures, different, separate, but for 4 days. The HIV viral load 170. Your CD4 count 700. Dr. Andrelli, 776. Parasites thick and thin smear was negative. AFB in blood was negative. Your hepatitis, EBV, and TMB antibodies negative. TB negative. Leptospira, Brucella, chlamydia negative. Your Fungitil, Aspergillus, crypto antigen urine, histoplasma in the urine was negative. We did a blood smear because one of our differentials was again malignancies, right? And we didn't see any. What we saw was toxic granulations. If that is something we can find in sepsis, it's not like clear cut. It's not if you find it, it's not equal to sepsis, just inflammation. There were some giant cells, monocytes, the SPEF to see if there was any, again, malignancy pointing to you to like multiple myeloma. The only thing that was kind of like out of the normal limits was the alpha-1 globulin. And if you look why, what are some of the causes of this increased alpha-1 globulin is inflammatory states. The IG quantitative was just decreased for IgM. Your flow cytometry in the blood, no blast and no lymphoproliferative disorders. And we did a CT test without contrast. Didn't show much lymphadenopathy. Everything was pretty much kind of normal. We did a TT ultrasound and everything was unremarkable.
Brissete, can I just make a comment that it's just to kind of make sure that y'all don't anchor on just a CD4 number. The thing that makes this more comfortable is the fact that the CD4% is 27%. That makes you feel like, yes, this is way beyond 15%. Remember, when someone's acutely ill, your CD4 number can drop. And the thing that you are going to rely on is really the CD4 number and making sure it's above 15%. And yes, I do know this patient, so that's why I try to join. Okay, go ahead.
Don't worry. Thank you. Thanks for that, Chris. Thanks for the fact. So here we have a patient with FeO, fever of unknown origin. And basically the definitions have changed with time. Initially, it was defined like 3 weeks inpatient for having at least an evaluation for at least 1 week without being revealing. That has changed now. Currently, the definition is 38.3 of temperature, more than 3 weeks. It can be on and off. It doesn't need to be every single day. And it can be inpatient or outpatient. This difference is most likely because with the advancement of technology, you can do all the tests. If the patient is pretty much stable, we can do those outpatient. And we don't need to, patient doesn't need to be worked up for 1 week or 3 days, like you see in the prior definitions. Basically, what they are asking is for a minimal diagnostic protocol or a minimal workup. And I will tell you what a minimal workup is, according to Harrison. And this guy, Dura, kind of like said or proposed another classification, asking who is my patient, right? Is my patient in the hospital, nosocomial, neutropenic, or HIV associated and classic? And you can look at the definitions later. But the main idea is a patient with 3 weeks immunocompetent, 38.3, and nothing revealing with your kind of like minimum workup. Again, based on the etiologies, you can classify the fever unknown origin in buckets, and infections is still kind of the most common. Then it will be inflammatory or autoimmune disorders. You don't want to forget your vasculitis. In the neoplasms, lymphoma, renal cell carcinoma, leukemias, and remember your D for drugs, fevers, and your endocrinopathies. There's something to kind of like say about fever of unknown origin, that up to 51 of the cases can remain undiagnosed, and that's huge, right? Most of these cases, however, will have a good outcome. That's like common, right? However, 12 to 35% can die because of some related cause. And this is just for you guys to see the amount of differentials that you can have from the fever. And then how can you approach it? Basically, you want to know, you want to get a good history and physical exam. History, remember the differences that we go through, did the patient travel, any kind of exposure, physical exam, any lymphadenopathy, any rash, any joint pain, things that kind of like point you to one of the buckets. And it's recommended, actually, if you see like in the algorithms that have been proposed, to stop your medications and refrain from starting antibiotics and steroids. And that was the reason why I asked that question: would you start this patient on antibiotics? What they consider obligatory evaluations? You want to have your CBC, your COMT, your hepatitis panel, CMV and EBV, which are very kind of like common, your TB and HIV, again, common, your cultures, your rheumatologic workup, ANA, rheumatoid factor, your inflammatory markers, ESR, CRP, and ferritin, your blood cultures, LDH, for your lymphomas, SPEP, and immunoelectrophoresis for your multiple myelomas and your like chest X-ray. If this is kind of like negative and nothing's popping out, you can go ahead and obtain a CT abdomen, pelvis, and echo. You don't want to forget your endocarditis and your low extremity Doppler ultrasound. And this is kind of like controversial, the next step. And many of the hospitals won't kind of like offer because it's not cost effective. The FDG, PETs, and CT scan, it's kind of like the only thing that will tell us, and it won't tell you on 100%, it will just tell you up to 50 or 60%. It will just localize the source. And why do you want to localize the source? Because you want to, the next step is biopsy. And biopsy, at least on this guy, we were trying to get a biopsy from the bone marrow. It would have birthed maybe liver, because he had a hepatosplenomegaly and abdominal pain. We think it's most likely coming from that. And again, if the patient's pretty much still and stable, you can just consider, it's not like give antibiotics and source steroids based on every case, right? And something I put in here in bold and red was to reevaluate your patient every step you take. You want to see, again, your history, go through your history, go through your physical, and what you want to look for are potential diagnosis tools, basically. So this is what happened to my patient. So he came in on the 15th. We started antibiotics. People started antibiotics, and we decided to give him a 7-day course of antibiotics. We started cefepime and flagyl. I'm not sure exactly what was vancomycin added. He started with a hemoglobin of 9.3, platelets of 147, and you can see on the 20, everything turned like he had a like big turn. And the big turn I mentioned is because I was kind of like reviewing his labs kind of in the morning, and his platelet just dropped from 81 to 22. At this point, I was like, I was an intern at that time. I was like, what's going on, right? What the team did was get a blood smear. That's something, if you see a sudden platelet drops, you want to do these things. You want to see what is my patient taking, right? Because in between the differentials, you have your drug-induced thrombocytopenias, and that can be like heparin or any other drugs. And the patient was receiving vancomycin, which kind of like give you that bump, less than 20K. You want to get a blood smear. And the reason why you want to get a blood smear is because the blood smear will tell you 3 things. It'll tell you, first thing, will rule out, this is like the pseudo thrombocytopenia, the clump platelets. The second thing is you want to rule things that want to kill, like will kill my patient, right? And those things are your basically DIC, TTP, and immune thrombocytopenia also. And the third thing that you want to see if there was any blast, because you were also thinking about cancer, right? You see the labs, no schistocytes. So you basically were left without, okay, this is not TTP. I can TTP breast, no TTP, no DIC. If you see the fibrinogen in this patient, the fibrinogen was actually high. The bilirubin total was 2. Again, it was increased, but you will expect to be indirect, right? And it was mainly direct. The other thing that really caught us our attention, and I think that was the reason why we started thinking about CBERS, is because of the ferritin. The initial ferritin in the patient, we already knew that our patient was like having this huge inflammatory condition, right? The ferritin suddenly bumped from 3,000 to 33,000, then up to 77,000. It was very, very remarkable for us. And we were thinking, okay, let's think about like differentials about elevated ferritin. And there are not too many things that can cause that elevated ferritin. If you kind of like go through the differentials, one of those are like Still's disease. This patient didn't have any like joint or any rash, so that was out of the picture. The other thing that can give you very high ferritin is your lymphomas. That it's not 100% ruled out, honestly. We were thinking about maybe we need a bone marrow to definitely rule that out. The other thing is that iron overload states. Iron overload states in a patient with transferrin saturation low, unlikely, right? Then we had severe infections, and the severe infection, kind of like the most common, it's Mycobacterium tuberculosis. And again, AFP was negative. The quantiferum was negative. We didn't have it like any clue. What we were left was with hemophagocytic lymphohistiocytosis. We did like run the score, and he was kind of like, we were 90% sure that this might be the case in this patient. Because this disease is like life-threatening, he was on board, ID was on board, and we all kind of like they decided to start him on dexamethasone. As soon as we started him on dexamethasone, the fever curve just dropped. And that was expected, right? But with these, the other issue was the hyperglycemia, hypernatremia. On the 20, when his platelets dropped, we kind of like talked with the patient and said like, hey, you're really getting sicker. I think it's a good time for you to go to the ICU and maybe consider some bone marrow biopsy to get answers and be able to treat you further. He kind of refused that. He refused on the 21, he refused on the 22, and he was transferred finally on the 23rd. At this point, patient was a little bit encephalopathic. We were trying to transfuse him, but we didn't know that he was raised on Jehovah, kind of like in these family, up until the 20 again. We were trying to kind of like, hey, if you don't receive platelets, you might die. Do you understand that? Yeah. On the 23rd, he finally said that, yeah, I want to like transfused. I want to get transfused. But at this time, people, like based on our attendings at the time, he didn't have capacity. We were able to contact family on the 23rd.
Brissete, I'm so terribly sorry, but I just wanted to point out, again, sorry for interrupting. Nadim actually is asking, could this be HLH?
Yeah, this is definitely like we think this is HLH.
Do you mind just sharing with us what that means, HLH?
Yeah, that's hemophagocytic lymphohistiocytosis. And basically, again, as I was telling you, this is what the lymphocytes get kind of like crazy. They start stimulating. There's no down regulations. There's no way to shut them down. And this stimulates the macrophage. And the macrophage go, again, crazy. And they create this cytokine storm. There are different types, the primary and secondary. The most common is this primary, and you see those in children. Again, everything what we have so far is from those studies. There are, this is a very rare disease. What we know is that in adults, there are basically this is driven by the immune dysregulation. And again, you have your three buckets. Those are the causes: infections, malignancies, and in rheumatological disorders. We put in the score. He did had 5 criteria out of the 8. That's why we finally said like this patient for us had HLH. Going back,
sorry that I'm just going to take advantage of Dr. Osorio being on the call. Sorry again. Dr. Osorio, since you did take care of this patient as a consultant, will you mind sharing your thoughts on this case? What would you say in this immunocompetent case?
I think that I was waiting for Brissete to finish, because I think this case is very interesting because, going by the timeline when we met him on the floors, this was a very competent individual that really looked like someone who's just having a fever, that looked more like not infectious, but more malignancy versus drug. Not drug, I would say less, because he really was coming from the outpatient. And wasn't really exposed to any other drugs except for his current regimen. So he decompensated really quickly. He benefited from broader antibacterial. The minute he went to the unit, then you saw that like meningitis medications were started and a lot of other things were started. But I think at that point, people were just kind of trying to do whatever they can for him. But we've, these, like the keyword for this is the bottom is triggers, like what triggered it. And my concern was malignancy that never really got worked up because he could have compensated so quickly. And unfortunately, he unfortunately passed away. And the family at that point did not want an autopsy. So we never really got an answer of what happened. So the main thing is what we thought was the overall, like what happened was what's on the slide. What's the trigger and why this person decompensated within 2 weeks? and passed away within 2 weeks of symptoms is the thing that was not answered. And I was, it was actually a really sad case. And I remember the team was very upset because he was very young, very, no issues, HIV controlled. And then within a week, he basically passed away. And there really was no answer to what happened. And I was hopeful for an autopsy, and I was a little bit upset about the comfort care, but I understand. but because I even brought up, the patient did not have HIV, was that something that we would have brought up? But I know it's a lot of different other issues. And I'm also the person that doesn't look at ages, so I know how I am. So that's what I would say. I don't know if Brissette wants to add anything further. Or
Thank
Dr.
you,
Leo.
Dr. Osorio. It absolutely does. And it does sound like a complex case. And, I really think you did a fantastic job there, Brissette, just sharing with us, what you learned just treating this patient. I know it's a lot. And really, and as someone that mentioned you have a wonderful handwriting. The summary that you provided, I think it's going to be something we're going to be taking with us. So unfortunately, it's 5:11. We're going to have to cut this short. Thank you, everyone, for joining. Thank you again, Brissette, for your case, and Dr. Osorio for staying back to share your thoughts on the case. We'll see you guys soon. Enjoy the rest of your afternoon.